Every moment matters. Every decision shapes recovery. All Things Neuro is a specialized neurocare organization focused on the diagnosis, treatment, and rehabilitation of traumatic brain injuries and concussions. A multidisciplinary team works together to deliver coordinated care, guided by advanced diagnostics. All Things Neuro and Neuro 360.
So go ahead and take it. So I'll mute myself.
Okay, that's nice. I'd like to welcome the thousands of people who are present today and the millions listening around the world. Thank you for that generous introduction. My pedigree is very different for a chiropractor. I practiced for 30 years in Stone Mountain, retired, got hired by Emory, was a hospital administrator at Emory for 12, became a consultant, and also served as the director of the community care network for chiropractic for the VA. In the VA, of course, we see many patients that have head injuries, but I think today we're going to concentrate a little bit on the patients that come into a chiropractic office that have been involved in an automobile accident. At Emory, I did work in the emergency room for 7 years. I ran a program there. We saw many who were in automobile accidents. Very seldom was a CT scan positive unless there was a small bleed, which was very rare. And they were released and wound up in chiropractic offices. Now, as a chiropractor, when you treat patients that are involved in automobile accidents, they fill out a case history form. In that case history form, their chief complaint on there. Chiropractors, as well as medical providers, concentrate on that case history to see where their chief complaint is, and then they go directly to the neck or the back or somewhere else in the spine. What you want to do is include that, whether it's a concussion or a Stanford concussion screening. Many of them are very short. Their own questions. Does he have difficulty rating? Is there balance issues? Or have headaches? That is incorporated or should be. Remember that you never get the right answers unless you ask the right questions. I've had chiropractors tell me, Steve, we don't see patients with brain injuries. I said, you may not see them, but they see you. So unless you ask the right questions, you're never going to be able to tease out that information. And when you do, what do you do with it? Part of being a good receiver is having a great quarterback. If you watch football, no team makes it to the Super Bowl without a great quarterback. A chiropractor has to be a great quarterback of care. Take care of what you're trained to do as far as the musculoskeletal system. And everything else, you direct. You direct the traffic on where that patient goes. If that patient filled out a concussion questionnaire and it is positive, they need to be directed to somebody who deals with concussions. Now, many chiropractors have gotten into this more and more, and they are starting to creep outside the sidelines. They call it creepers. In the hospital setting, everybody seems to do it. You find pain management physicians, physiatrists, and anesthesiologists now doing spine surgery. They drive spine surgery surgeons so crazy that now they're giving injections. And the physiatrists hate them for that. And the neurosurgeons don't like when physiatry does microdiscectomies, fusions, and ablations and other procedures. So if you're a chiropractor taking care of these patients, if you want to do impact testing If you want to do VNG testing for posture and balance, if you want to incorporate in your practice, that's fine. But you may get to a point where you are sitting down under the hot lights in a deposition, and the defense attorney is going to ask you, as a chiropractor in the state of Georgia, are you qualified to do these tests? Are the machines that you use FDA cleared, or are they FDA approved? Does the diagnostic testing that you're doing come with a CPT code? The questions can get thick. You may not know the answers. So my suggestions for the chiropractors on this line that may be doing that, that's fine if you want to do that in your practice, but just be prepared to defend yourself. Make sure you have certification. I do a lot of courtroom testimony and depositions. I've done 83 in the last 3.5 years. I just sat in on 5 8-hour depositions regarding CTE in football players. It wasn't high school. It wasn't the NFL. It was somewhere in the middle. Since I signed a gag order, you can figure it out where somewhere in the middle may be. But they wanted to know how a chiropractor could testify in a CTE case. Well, I have a certification from the Brain Injury Association of America. It's called a CBIS, which is a Certified Brain Injury Specialist. It's not a degree, but it's a certification, and it keeps me from getting Dauberted. So if you're not familiar with a Daubert motion, it's when the defense files a motion with the court to have you removed as an expert witness. So you don't want to be removed as an expert witness at any time, and defending yourself against a Daubert motion can cost you thousands and thousands of dollars. So that's something you need to consider if you're going to do your own brain diagnostic testing. As far as the treatment, you can treat your patients like you always have. And you can use all the therapy equipment that you have always used to take care of their verticals. And when I say that, I mean muscle spasms, headaches, migraines, and of course, neck and back pain. And that's what we specialize in. On the pain management side, there's a lot of pain management techniques that deal with patients who have suffered concussions. All concussions are traumatic brain injuries, but not all traumatic brain injuries are concussions. So there's 3 types of TBIs. One is mild, one is moderate, and one is severe. And it's usually based upon the Glasgow score. So a Glasgow score, the GCS, the Glasgow Coma Scale, usually tells you where you're at. So when a patient is assessed at the scene of an accident, the EMTs do a Glasgow score. Glasgow scores run from 3 to 15, with 3 to 8 being the most severe, 9 to 12 being moderate, and 13 to 15 being mild. So 13 to 15, the patient is awake. They're assessed based on eye movements, general movements, and verbal skills. So can you speak? Can you answer my question? Can you move your eyes? Can you blink? And can you move your arms and legs? So they are assessed on those 3 levels, and it's determined whether or not their Glasgow Coma Scale is mild, moderate, or severe. So it's technically, it's a clinical tool to assess a person's level of consciousness. And you should ask the patient if they did that. And if it's possible, you should get that information from the patient, because they usually have exit information from the emergency room. And the GCS score is usually on their exit information. That also gives you a little bit more intel upon what the patient scored, either on the way to the emergency room, at the scene, or in the emergency room. Now, you have to remember that a TBI, a traumatic brain injury, is an injury to the most complicated organ in the body, the human brain. There are 86 billion neurons, give or take another 10 billion neurons, and approximately 400 400 trillion synapses, connections. So there's a lot that can happen, and it's your job to help direct the patient on the proper place to go. But all patients that you suspect of having a TBI deserve a certain amount of rest. I was a chiropractor for a high school football program for 30 years. There are protocols in place for people that come off the field and they are suspected of having a traumatic brain event. You want that patient to rest. Many of these TBIs are going to heal on their own, but the body has a long memory. It usually takes 6 weeks, even for a minor TBI, to resolve itself. You want to keep the patient limited in their activity, limiting their computer skills, getting more sleep, limiting the amount of reading, the amount of television that they watch. You basically want the brain to calm down because it's very difficult to measure that injury. There are advanced diagnostic testing if a patient is still symptomatic beyond 6 weeks, and you can always go ahead and do that. Some of the other testing, if you suspect a brain injury, of course, is an MRI. Most of the time, the MRIs are negative. You can order diffusion tensor imaging, a DTI, which shows axonal shearing. You can order a neuroquant, which is a volumetric test to see if there's been any brain atrophy over a long period of time. There's a PET scan that goes ahead and measures the brain at a molecular level. There are many tests that you can use, but those are further down the road. Your job as a chiropractor is to go ahead and identify it, do your chiropractic work, and refer that patient on. So these TBIs have different components. They have a psychological component and they have a cognitive component. When I say cognitive, it interferes with the patient's executive thinking. Can the patient carry on a normal conversation? Do they search for words? Psychological is anxiety, depression, and anger. So many of these patients see a neurologist or a neuropsychologist. For those of you who don't know the difference, a neurologist deals with brain and a neuropsychologist deals with brain and behavior. Those are two totally different things. So in the case of personal injury, it's very important that those patients do see a neurologist and a neuropsychologist. And it's also very important that you interview somebody in the household because people with brain injuries don't always know they have a brain injury, but yet the person that lives with them suspects something is different. So if you are seeing a patient, it would not be out of bounds for you to call the patient's spouse, son, family member, coworker, as long as it's HIPAA compliant, and go ahead and ask them, can you tell me about John before the accident? And can you tell me about John today? Has he changed? Oh, he forgets everything. He got lost coming home the other day. And I've had patients that I interview on the phone as a life care planner, that I construct life care plans, which is a dynamic document that captures specials all the way up to a patient's statistical life expectancy. And when I mean specials, I mean all the treatment that the patient gets today as a result of an accident is the treatment that is rendered today as the result of an accident. It's not going to deal with what Mr. Jones needs for the next 45 years. That's what a life care planner does. So we're concerned about if the patient needs any additional home care, because that gets extremely expensive. There's a tremendous amount of pressure put on a spouse if there's a brain injury involved with their spouse. It's a lot of stress. There's a lot to consider. There's a lot of care that's necessary. Some of these conditions don't go away They get worse over time. Dementia is an umbrella term that's used for decline in the brain's ability to function. So dementia is a term used like dermatitis. If you go to the doctor and you have a rash, he tells you you've got dermatitis. Is it eczema? Is it impetigo? Is it a spider bite? What is it? Dermatitis is a catch-all term. Dementia is a catch-all term. Many things that fall under the umbrella of dementia. Traumatic encephalopathy syndrome, CTE, Parkinson's, Alzheimer's. They all fall under the umbrella of dementia. Many of these TBIs, they lead to dementia over a period of time. The brain has a long memory. I don't want to get into the anatomy of it because a lot of you find it boring. But, these depositions were extremely thorough. So I probably know more about brain than my own brain knows about brain. But as far as taking care of these patients, you just have to make the appropriate referrals when you suspect that a patient has a brain injury. Because if you want to do personal injury, then please do it well. Okay, please have the patient's concerns. You are not a bank. You can't make money on every vertical by crossing the lines and making yourself an expert. Because when you're deposed, that'll be exposed, and you don't want to be that person. So diagnostic testing is great, but wherein lies the treatment and how long that treatment is going to be necessary should be in your medical records. So keeping your medical records tight is extremely important. You want to go ahead and make sure everything is documented in those records, and you also want to state what that patient is going to need moving into the future. You would not read a 25 chapter book and stop at chapter 23. You don't know how it ends. So we want to know how the situation with a brain injury is going to end for a patient. And it's important that you lay it all out in your medical records. Does anybody have any questions? Because I don't want to take you too far into the weeds. I know the weeds are probably where you learn 90% of the best information that you could probably learn. It's in the weeds. But any questions so far before I rattle on?
I've got a couple questions, of course. Um, what have you found in the studies about what happens when you wait too long to actually do something about the brain? Like, and where is that window where it's okay if you don't catch it right away, it's not too late, but that you really don't want to go beyond X amount of time because now we're looking at this situation.
Do you know what the definition of a mild brain injury is? When it happens to somebody else. Okay, not when it happens to you. So even a mild brain injury is serious. You catch it when you can. If you don't ask the right questions, it's very difficult to catch it. Okay, so you have to sit there and you have to ask your patient a whole series of questions, and then you have to make sure that you make the appropriate referral. It's never too late. Okay, that is the interesting thing about brain injuries. Patients don't come in with them right away because they don't think anything's wrong with them. Many times they come in after the fact when they can't remember where their car keys were. I mean, it is a scary thought. I had a minor medical procedure 10 years ago, and they had to put me under for it. And I came through it like a champ. It was an outpatient procedure. 2 days later, I got lost going home from my office. I had to stop and pull over in a gas station. I had no idea how to get home. I had to look around and I had to go to the person behind the desk to ask him where this road was. And I went up and down that road for years. So it is a scary thing for some of these patients. They realize it and then they seek help. And that is a way to explain it, because I've been asked that question when I've been deposed. Why did the patient wait 3 years before they came in? Well, they waited 3 years because they didn't think anything was wrong with them. People with brain injuries think everybody else is crazy. They don't think anything's happened to them. They just wonder why people react differently to them. So it's never too late to get care for a brain injury. Of course, you want to identify it as close to the source as you possibly can to give the patient as much care as they can. And then that helps with the healing process. One brain injury is bad enough. A second brain injury, a second trauma to the brain is 5 times worse. So the brain has a long memory, and brain damage gets to be progressive because signals are sent out from one axon to the next. In the case of traumatic encephalopathy syndrome, what happens is, due to the shearing of the axons, the tau proteins in there disassociate. They become hyperphosphorylated, and they fall down around the vessels within the axon. They shoot off another signal to the axon behind it, and it dies. They shoot off a signal to the axon behind that, and that dies. So remember, you have 86, 96, 100 billion neurons. So a patient can go a long way without realizing they have an issue. And then, of course, whatever area of the brain is affected, that's where it's going to show up. So if the injury is in the frontal area, where most of them are, you're going to have a lot of cognitive issues. If it's in the occipital area, you may have visual disturbances. If it's in the temporal region, you may have a problem with speech, either understanding it or actually forming it. So you have to be aware. What was your next question, Jen?
My next question is, I think that there's a huge misconception about how easy it is to actually get a concussion. And one of my big learnings since I've been working with All Things Neuro is that it takes very little. Maybe you can explain how you don't have to go through a windshield, and like what you've seen actually be much larger. You talked about the mild TBI, but how that can actually happen. Maybe you could talk about the different scenarios of this could be this, and it is actually a concussion.
Well, first of all, I think, we know from chiropractic school, you don't have to strike your head to have a concussion. Um, of course, you can get a concussion from striking your head, but they call it a contra coup injury, where somebody who has a whiplash injury's head rocks forward and then it snaps back. Well, the brain is encapsulated within the skull. The skull is a protective mechanism for brain. And the skull is not right up against, the brain is not up against the skull. There is a space there surrounded by cerebral spinal fluid. And when the brain goes back within the skull, the concussive force of the brain against the skull is enough to cause a TBI without the skull actually striking anything within the automobile. It's interesting because when I had patients that came in, a lot of times that both the couples were in the car. Husband was the driver, the woman was sitting in the passenger seat. We got rear-ended. Did your head hit anything in there? No. Did your head snap forward and back? The driver would say no, and the wife would say yes. The passenger, yeah, his head almost hit the windshield and then snapped back. I saw it. My head was turned talking to him. So you don't know yourself as a patient if you've had a whiplash injury, and certainly you may not think that you had, and you may not think that you've had a concussion. And you can develop symptoms within hours, days, or weeks, or months, or years. The brain is extremely complex. It was a situation where there was and this was years ago, this 30-year-old guy was involved in an automobile accident. He was a friend of mine. He was a friend of another chiropractor. And after the accident, he called his chiropractic buddy and told him that he was involved in an automobile accident and that he wouldn't be in the office, for treatment early in the morning. He was going to sleep late. So he wasn't cut. There wasn't a tremendous amount of damage to the car. At 9 o'clock in the morning, the chiropractor's phone rang. It was his friend's employer wondering why he didn't come to work. He said, I just spoke to him, not that long ago. He said he was in a wreck and he was going to sleep in. He said, well, he's not answering his phone. It's not like him. So he went over there and his friend was dead. He was sitting in front of the television set with the remote control in his hand. He didn't think he had any problems. He had a bleed. So over a period of time, he just went to sleep and that was the end. So, it's extremely sensitive. People are injured. You don't have to have a mark on you. I had an attorney say, Barnett, what's the difference between an objective and subjective injury? I said, an objective injury is when my back hurts. A subjective injury is when you tell me your back hurts. Are you lying when you tell me your back hurts? I ask patients how they feel. That's what doctors do. The patient responds and tell me they have pain or they have dizziness, vertigo, if they have a headache. That's what I put down in my notes. I don't put them through an inquisition. They're here for care, and care is what they get. These are the findings. These are the facts. There's one thing you'll know about a case. If you do personal injury, facts don't change. The facts of the case are the facts. They don't change. So you just need to document them and just make appropriate referrals. You never lose a patient by making an appropriate referral. Remember that. If you don't remember anything, remember that. Any other questions, Jen?
Of course. I was one of the obstacles we have, and I think it's probably pretty common with chiropractic when they have our mutual patients, is that they often forget their appointment or they're scared to drive. And so, what are some unique attributes that you find, or maybe the chiropractors need to be aware of, that it's an indicator that they likely have a concussion? Not just like
An
they have
indicator
headaches,
to the
but what are
patient.
some behaviors that are kind of specific to those who've had head injuries, and maybe not saying, oh, I just can't sleep very well, but patterns of behavior that is pretty common when they come through the door that they might be looking out for?
Oh, the best thing to do is have them fill out a questionnaire. Patterns are, patterns. Searching for words, okay. Being really irritated if they have to wait into the waiting room. Irritated beyond what you would consider to be normal. Losing your filter and trying to, you know, uh, have a social arrangement with one staff member. I had a patient that told me her father was 85 years old. They can't go out to eat anymore with him. I said, why? Does he have difficulty ambulating where he can get into the restaurant? No, he's great. He hits on every waitress that is in the restaurant. No matter how many times I scold him, it's always the same thing. He always wants to know everything about them. He'll touch them. He's totally inappropriate. I can't bring him to a restaurant anymore. Okay, so obviously he's affected. You lose your filter. And you'll see that with some patients. They may make inappropriate gestures to staff members. They may get inappropriately angry if they're in the waiting room. They may be constantly forgetting their appointments. There's usually a whole series of things. But in Brooklyn, we used to say, hey, they ain't right. Okay, they ain't right. So, if you're a doctor, you should be observant and you'll know that that patient is just not acting right. We need to get him somewhere else. And I've sent patients out and I've refused to see patients because of that, because they have abused staff members. And I was afraid to see, how that would turn out. So I would tell them, listen, you can't come back to the office anymore. Your behavior is not appropriate. You need to see somebody. So yes, general behavior is important. You need to be a custodian. You need to own that, and you need to document that in your notes. Next question. I know you must have some more.
Of course. So I know that you started LCP Pro. This is one of your latest parts of your career, as of, I would say, what it's been 8 years-ish that launched or that you were forming it. And
Almost 6.
okay, I know it was right around COVID time when we were talking about it. Have you seen an uptick or a change in how brain injuries are looked at, prioritized, valued? How that's come to the scene from when you started doing that versus now, or has it been consistently like what is on the court side in litigation? Talk about what that brings to the case and how it's been received. Translate that for me with your experience.
Well, that's a great question because there's been a groundswell of interest in brain injuries. And, when I started practicing in 1979, and that's 47 years ago. There was nobody doing any of this work then. Brain injuries were not recognized as serious from automobile accidents. And as we got more education and as the NFL monetary award fund became known and all the research and the litigation that involved former NFL players and traumatic brain injuries and CTE, there was a tremendous amount of attention placed upon head injuries. So the public became much more aware of brain injuries than they ever had before. Of course, some people might say, well, yeah, I probably had one of those. I played basketball in college. I had a concussion in 1973. There was no protocol for treating a concussion back in those days. You got back on the field or on the court, or you were called a name that rhymed with a female body part. Okay, so if you only stuck up 2 fingers and you only missed by 2, you were back out there on the court. There was no protocol. So over 40 years after that concussion, I was notified by the NCAA that I could participate in a program where I could have a visit with a neuropsych and neurologist and have an MRI on my brain. So of course, now when I get angry or I get upset, I think, oh boy, maybe it's the early showing of, that traumatic brain injury that I suffered. So when you say there is no time limit, over 40 years after I had a concussion, I was contacted by the NCAA. There were serious concerns about that. There's litigation that's going on about that right now. So you just have to be able to identify it, become sensitive. More people know about it, and more attorneys obviously know about it. So attorneys are out there looking for doctors that know how to recognize it and doctors that know how to treat it. And when I say treat it, I don't mean treat it themselves. I mean make the appropriate referral to have it treated. Get the medical records and put them in your notes. So, being a good personal injury doctor means being able to co-manage and quarterback these patients. You do the best job for your patient, you need to refer them on to a specialist, somebody that sees it and deals with that every day. Get the records, put it in your notes. So if you're ever questioned on that, you can go ahead and have the appropriate response. If your patient has a drug issue, you should go ahead and send them to a drug rehabilitation center. If they're an alcoholic and you smell alcohol in their breath, you should refer them to Alcoholics Anonymous, and you should put it in your medical records. Because I'll tell you a quick story. I'm famous for my stories. Some of them are true. Well, most of them are true. So a patient went into an emergency room, not in the hospital I was working in. He didn't come in. He was brought in at 3 o'clock in the morning. He lost control of his car and he had a head injury. The neurosurgeons were on call. They operated on him for 8 hours. They didn't expect him to live. He made it. Not only did he make it, he made a complete recovery. A miracle, a fabulous surgery by a great doctor. 2 years later, he comes back in. He, unfortunately, this time he did not make it. He was involved in another automobile accident in the middle of the night, and he was gone. About 6 months after that, a sheriff's deputy comes into the hospital and serves the emergency room physicians and the neurosurgeon with a lawsuit. Now, this patient was uninsured. He had no money. He was indigent. The first surgery was a miracle. The second surgery, they didn't have the opportunity to perform. They realized he had an alcohol problem, and they did not refer him to a psychologist, to a licensed clinical social worker, or to an alcohol rehabilitation program. And because it wasn't documented in their notes that they referred him to an appropriate resource, full well knowing he was an alcoholic, the emergency room physician settled the case. The neurosurgeon said, "Hell no. We did a 10-hour surgery on him. We never got paid. We're not settling anything." The neurosurgery practice got sued, and the patient's family won because they weren't referred to an appropriate source when the doctor full well knew that they measured his blood alcohol level when he came into the hospital. He was unconscious. And when he regained consciousness, they realized he was an alcoholic. When they spoke to the family members, they realized he was an alcoholic. None of it was documented in the notes. When I started working at DeKalb Medical Center, which is now Emory, I was sitting in the neurosurgeon's office, and his surgical nurse came in. She said, "We're doing the surgery this afternoon." The doctor said, "Make sure that you have a 6-pack of Coors in the refrigerator in the room for the patient." I started to laugh. I said, "You can't be serious. You're going to put a 6-pack of beer in the room for the patient post-surgically?" He said, "Hell yes." He said, "He's an alcoholic. It's documented. I don't want him to go into withdrawal when he comes out from surgery and he starts to twitch and shake and go into muscle spasms. He's going to break the screws in the plates. We're instructing to give him 1 beer every 3 hours for 2 days." I mean, I couldn't believe my ears. But yet the guy was prescribed beer while he was in the hospital. So documenting your records, referrals to appropriate sources become extremely important in caring for patients. Don't try to do it all on your own if you're a chiropractor. And if you don't do it, be interested in it. You're taking care of a patient's health. You're a doctor. You're more than a spine specialist. You're a doctor. You're a physician, whether you like it or not. You may not be a physician in the state of Georgia, but you're a physician in 37 other states. You're also a physician with Medicare. I'm a physician at the VA. It says it on my paperwork. So you are responsible for taking care of patients. Any other questions there, Jen?
I have one more, and unless someone raises their hand, I'll just keep going because I always enjoy to hear your perspective. I think we all know when we're in the personal injury space that hospitals miss the head injuries and miss a lot of concerns that are severe when they come into the emergency room and then are discharged, and that they focus on just making sure they're not bleeding out and going to die. Do you see that potentially changing now that we're learning more about the severity of brain injuries? Or do you find that certain hospitals are, I mean, do you feel like there's a trend where more of them are going to be caught there? Because that, I think that I've been astonished by that part of the statistics about how many are missed, even in trauma center emergency rooms. So what are your thoughts on that?
Well, first of all, I agree with that because I worked in an emergency room and I saw what happens. And when a patient comes through triage in an emergency room, usually they don't even see a physician. They see a nurse practitioner or a PA, and they'll assess them. And in many cases, they don't x-ray them, even if they have neck pain. Very seldom are they doing a CT scan, even less seldom when they do an MRI. Because a lot of patients who are ambulatory and walk into an emergency room, 25 to 50% of them have no insurance at all. And because they're uninsured, the hospital has a horrible collection rate on these patients. So usually they're treated and streeted. Very seldom are they going to do advanced diagnostic testing on these patients, unless you complain long and loud enough. Now you're going to get care, you're going to get good care, but it may not be enough care. Job of an emergency room is to stabilize you and refer you to somebody outside the walls of the hospital. They don't like anything that's litigious, especially if they're not getting paid. So even the secondary appointment at a primary physician's office is difficult. There are many primary care physicians that won't see you if you tell them you're involved in an automobile accident because they don't want to get a request for medical records and they don't want to be deposed. So these patients usually get treated and treated very quickly. And they don't want them in the system. They don't want benign necks and backs in the system. They don't want post MVCs. They don't want those patients because they're litigious. And physicians hate attorneys because they think they're going to get sued for malpractice. I mean, I worked in a hospital for 12 years. I was in the lunchroom. What they didn't pay me in salary, I took out in food. I spent a lot of time in the lunchroom. So, yeah, they don't get very good care in an emergency room. That's not the place for good care, unless you're very ill, of course. An emergency room's job is to stabilize a patient and move them on to the next level. So these patients, unless they have lacerations, unless they have very strong symptoms, fractures, um, they're going to have them out of the emergency room very quickly. They'll wait longer than their treatment took in most cases.
I never thought about the economic area of this, and how those who have no insurance probably receive a lot less screening for brain injuries than those who can pay. So that is an interesting thought. All right, I did say that was my last question, but I do have one more question, okay?
And I have one
Because
story, but go ahead.
good. So we'll just do those two things unless someone interrupts. So I think sometimes chiropractors can be concerned that when they're in the personal injury space, if another bill like testing comes in, it will impact their ability to get paid for the services. Because unfortunately, in our industry, the bill does not always equal what we receive, and that's because there's a shortage of dollars based on insurance limits, right? So what would be your advice on a topic like that where, we're not dealing with much to work with? We all want to help this patient in what capacity that we can, but maybe speak on how that translates to value, and when it's worth it and when it's not.
Well, what I can tell you is there is never a right time to do the wrong thing, and there's never a wrong time to do the right thing. So if you have a patient that exhibits symptoms, don't decline to get them an MRI because it's going to be $2,500 taken out of the pie of a settlement. To see is to know, and not to see is to guess. An MRI is the best way we can objectify an injury as a chiropractor, for the most part. Don't worry about, you know, practice good healthcare. Move the patient on appropriately. If the money comes out of the settlement, it comes out of the settlement. You shouldn't be thinking about yourself when you're taking care of your patient. You should be thinking about your patient when you take care of a patient. That's the best advice that I can give to anybody. If you do things for the right reason, you'll be successful. If you do them for the wrong reasons, you won't be. Okay, so my story is I had a patient. We closed at 7 o'clock at night. I worked from 6 in the morning till 7 at night with lunch on the fly. This guy comes in on crutches. He's bandaged from head to toe. He comes in hopping on a pair of crutches, sits down in the waiting room 5 minutes before I close, and said, I need to see the doctor. I'm thinking, gee, this guy's got road rash, from he's got road rash. So I bring him back in a room and he sits down and you could tell it's painful just for him to sit. And I said, what happened? He said, I was in a motorcycle accident. I said, yeah, it looks that way. I said, so you filled out the case history form. Tell me what happened. He said, well, it was at 2:30 in the morning. And I felt like stopping and saying, stop right there. Because nothing good happens at 2:30 in the morning. That's what I used to tell my kids. So it was at 2:30 in the morning. I'd been drinking, half the night. He said, and I had to get home and I was flying, speeding my ass off. Getting home, I come into the subdivision and these idiots are walking their dog at 2:30 in the morning. I almost killed them. I had to lay my bike down to prevent running into these morons. Okay. And I broke my leg. I tore the skin off my arm. I separated my shoulder and I'm hurting, man. I said, I could see that. And he said, I need care. I said, well, are you going to file this as some sort of an accident? He said, of course I am. He said, I need treatment. I don't have any money to pay these medical bills. I said, well, it sounds like you were at fault in this accident. He said, how do you figure that? He said, these people had no business being outside without a reflector on at 2:30 in the morning walking that stupid dog that they have. They almost killed me. I said, okay. I said, well, you have road rash from head to toe. I said, there's no way you could even lay down on the table, even if I would treat you. So I have a good friend who's a great doctor, Dr. Polidor. I'm going to give you his number, and you can call Dr. Polidor and make an appointment. So I still kid Shevin to this day about sending him an uninsured patient who wanted to sue the people that were in his way at 2:30 in the morning because he broke his arm and leg and had road rash. So that's why some people don't want to get involved in personal injury. But I didn't ask him about a head injury at that time. So if you're on the call, the best thing that you can do is do the best work that you always have done. Ask the right questions, get the right answers. If the patient's suspected of having a head injury, you're not the expert. Move them on, get them checked, help the patient get all the care that they need, and then the attorney will respect you for quarterbacking that case and being the one to go ahead and catch it. As primary care doctors, we catch a lot of stuff as chiropractors that we don't treat. Kidney stones, cardiac issues, and worse.
And cancer.
So we don't treat them, yes, but we catch them. And the fact that you catch them, believe me, your reputation will precede you. Your reputation is the only thing that precedes you. And you'll be surprised in the healthcare community that people will know who you are. I had a patient, this is the last story. I had a patient that came in and she sat down in the room and she said, I just came from Dr. Blanton's office, my primary care physician. And boy, they were bragging about you. I said, they were? Yes, he was talking to his PA. he told me about the patient that you sent over there that you x-rayed, and they had prostatic cancer that had metastasized to the lumbar spine. And they were just saying that, thank goodness he walked into the right chiropractor's office. So my patient, who was in the office at the time getting treated, heard it. And I'm sure, all the people on this call have a similar story. But he sent me more patients because of that than any physician that I ever got patients from. Simply because he realized that I look, I listen, and I try to do the right thing. And that's it. Have a great weekend.
Well, thank you for coming on and speaking with us. I know that you probably regret you didn't know some of what you know now back then. And I'm so grateful that you have learned and are a spokesperson to chiropractors and beyond to help continue to build this movement and mission to educate everyone on the importance of brain injuries, especially early on. And so with that, I want to thank everyone for joining us today. This will be recorded and we will have this posted. So appreciate Dr. Barnett for giving your time today.
Follow for more tips and visit our website, allthingsneuro.com.